CHÉOS exists to improve health outcomes for BC, Canada, and more at chaos.ubc.ca.
My name is Amy Salmon. I am the Associate Director of the Center for Health Evaluation and Outcome Sciences, and it is my great pleasure to be introducing Dr. Conklin and team and their talk today, which is entitled Surgical Prehabilitation for Better Patient Outcomes, the PREP study, the results of a patient-oriented research feasibility study. Before we begin, I'll acknowledge with gratitude that we are meeting today on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I will introduce Dr. Conklin, who will then proceed to introduce their co-presenter. Dr. Conklin is a valued member of our team here at CHÉOS. Dr. Conklin is a social nutritional epidemiologist and assistant professor in epidemiology and outcomes research at UBC in the Faculty of Pharmaceutical Sciences. Dr. Conklin received a Michael Smith Health Research BC Scholar Award to lead a program of social epidemiology and metabolic outcomes research, otherwise known as SUMCORE, to support healthy aging and reduce heart health inequities in women in Canada. Using both quantitative and qualitative research methods, Dr. Conklin's lab examines how broader social determinants, such as social ties, job loss, and related factors impact diet, obesity, and hypertension differentially in aging women and men. Dr. Conklin is also an expert in applying a gender lens to health and healthcare research and in population studies using international survey and administrative data sets. Dr. Conklin, I will turn this over to you. When we get to the question and answer periods, I'll ask folks in the room to turn on their microphones when it's time to speak. But for now, can everybody please make sure that their microphone is turned off? Dr. Conklin, over to you.
Thanks, Dr. Salmon. Really appreciate it. So I'm delighted to share some new results here from a patient-oriented study I was involved in. And I'll give you a little bit of background and then I'll introduce another member of my team who's here with me today. I'm very grateful to Kim. So for some of you, you may be aware that abdominal surgery is quite expensive and comes with extreme burden on the patients as well as families and even society because of post-op complications like infections, etc., and time off that's needed for healing. And so a lot of abdominal surgery for chronic conditions are on the rise, and so are the costs. And there's a desire to address this. And self-management support before surgery is an area of new research that's really burgeoning. And it's thought to be able to improve outcomes of surgery and by extension, reduce costs by putting people into a better health state before they go into their surgery. Structured support, however, for self-management to prepare for colorectal surgery is not routinely offered to patients in Canada. In May 2018, we conducted a focus group study, which has been published with patients who had received colorectal surgery at St. Paul's Hospital, where some of you are physically located right now. And the idea was to explore their preoperative experiences of exercise, diet, psychological stress, and to inform the design of what would be a prehabilitation program that I'm going to speak to you today about. So the results of that earlier focus group study showed a number of things. One was there was a strong preference for a single point of contact for patients to obtain information that was expert vetted about the process of preparing for surgery in different areas and how each of those areas would help improve their surgical outcomes. Many had a preference for being independent and accessing relevant information at a time that was convenient for them. So there really needed to be a lot of flexibility embedded into a future program. And patients were interested in a prehab program that would give them some structured support for self-management. as long as it was personalized and purposeful. So we had a big task ahead of us. This patient-oriented project was therefore a feasibility study that had two goals. The first was co-design with our patient partners a web-based intervention of structured support that we call prehab for patients preparing for colorectal cancer surgery in the province of BC. And then to explore the feasibility of this new intervention and possibly the addition of a health coach who could deliver additional active support by telephone. So a little enhanced active support arm. We had both of those in mind because there's some research in the UK that shows that a health coach or an individual that can help coach a person through their self-management has added benefit. And can be useful in this area. So my team members were, of course, some important clinical knowledge users, Dr. Brown and Dr. Karamudin, two colorectal surgery clinicians at St. Paul's who helped with this study and were obviously important for the final piece that I will show you later. And then I had some co-investigators and collaborators who were my additional scientists who helped with the expert vetting of all of the information that went on to our prehab program intervention that was web-based. But most importantly, we had a patient advisory group. And this is where I'm going to pause and invite Kim to introduce herself today. Kim, would you like to share?
Hi, everyone. I am Kim Furneaux, and I am an accountant in public practice. I have 2 grown children, and throughout my adult life, I've participated wherever I can in studies. For example, with my daughter, they asked me to participate at St. Paul's in a gestational diabetes program, which I did and found very interesting. With my second child, they asked me if I would participate in how the kidneys function in my unborn son, which was very interesting. However, I'm a 2-time cancer survivor, and with the second being colon cancer. Dr. Brown was my surgeon and amazing. This study came about just after I had gone through my surgery and the stoma and then the reversal, and I was all for jumping in when Annalyn came looking for people to participate and help her with the studies from the perspective of somebody who had gone through colorectal cancer. So here I am. Thank you.
Thanks, Kim. Really appreciate it. And Kim was a co-lead on the grant that was supporting this work. So for the first part of my talk, I'm going to walk you through our intervention, which I'm very proud of as a group, what we created. And so here's the link. I would invite any of you, if you do happen to have laptops in front of you, please feel free to log in and walk through this with me. For those of you who don't have laptops, I'm going to give you a series of screenshots. Here's our landing page. We work together on every aspect of what you see here. So the word for bowel surgery, whether we should use abdominal surgery, colorectal surgery, or bowel surgery. And the patient advisory group was very helpful in identifying the appropriate language and what should and shouldn't be included, including the color scheme, the layout. All of these images come from our own resources. So we didn't use any existing pictures. We used what we have created ourselves or made pictures of ourselves. And you'll notice that at the bottom, there's a quote. And again, our patient advisory group was very helpful in providing personal quotes for different components of the website. At the bottom here, thinking back, I realized that building pre-surgery strength meant taking one step at a time. I soon learned that there was no time for hopeless thoughts and negative thinking. That's from Glynis. And the next page, sorry, that's the next part of that first page, just sort of scrolling down, is why would you prepare for surgery? So this was really important to communicate to patients of why it's important and what this website or this intervention web-based prehab program can offer. So we were explaining in as clear language as we possibly could what was the goal here and why it was important. So we bring out that importance using color and text and mostly blue because it's very calming. We wanted to create a very calm sense beforehand because of, again, pre-anxiety before surgery. So addressing a lot of issues in multiple ways. Here you'll see some drop-down menus. So on that very first landing page at the very top, you'll see a bunch of tabs. Underneath those tabs, you'll see before pre-surgery, we have a page for each of the 4 areas. So that's what makes this multimodal. This was another piece of interest, was a lot of the research that's been done early on prehab has been focused very much on exercise, right? Because often exercise after surgery are what we often think of as rehab. So that's where most of the focus has been in the literature. And we wanted to have a well-rounded approach, and that's more common now. We had some post-surgery information, I'll get to that, and some patient connections, because again, that came out in our focus group, that peer support was really important. That wasn't something we could manage as a website or have that involvement of in creating a peer group of any kind, peer support group, but we had at least had a page about the importance of that and linking to other resources where patients could find that information if they felt that that was helpful to them. And then some frequently asked questions that we gathered from other websites and added on with our patient advisors. And then where people can find out information and who now is this website and who's involved. So one of the key pieces at the top I've highlighted here is that all resources and links that are provided are expert vetted and evidence-based. So we did our very best to find the most latest research, to use existing resources that have already also been vetted in the States. They're strong for surgery. We used a lot of the resources from them that are more broad, and that's been trademarked, but we link to them. And then how it works. So people can read about, resources for quitting smoking, if that's relevant to them, how they can eat well and limit their alcohol, staying active, and then the mindset and coping with stress. And again, how we phrased all of that, we didn't say diet quality, we used eating well. So again, the language was really important, and we had a lot of advice from our patient advisors on that. At the very bottom of this first page, so this is the first front page, we have this sort of staggered image of what the idea was behind our theory of change of this sort of website intervention. The first being the most basic, which is the educational content. So that's essentially what we're providing here. And then for those who wanted to reach out, peer support and connections adds an extra layer of support. That's not something that's in, that we necessarily directly provided. And then the active support, and I'll get to that later. And then at the bottom, we have a disclaimer about what this website can and cannot do, and addressing liability issues. And then at the very bottom, you can click back to top, and it links you right back to the top. So this on our, if you were to go into each of those tabs about pre-surgery, this one is our quit smoking tab. And again, on each of these pages, we refer to the research. What does research tell us? Well, it tells us that patients who stop smoking 1 month before surgery have better outcomes and fewer complications. So just a month. It doesn't take, 6-7 months. Takes a little bit longer than 2 weeks. Diet might be more, immediate after 2 weeks, but and then why quit smoking to prepare for your bowel surgery? So we go into some of that research, and we provide links to that and go into more detail, and then provide all of the resources that are available to help people quit smoking. The same for our eating well. We have the same piece, sort of same layout. We have an image. What does the research tell us? Well, it's important to eat a healthy diet to make your body strong before surgery. Again, we give the literature on that. And the same with staying active. Again, research tells us that when you stay strong, it can help you get healthier, and you only just need a small amount of time every day, such as walking an hour. And then the coping with stress. This is the one image I have to say we did purchase, but most of the other images are ones that we took ourselves. Then post-surgery, we have a few great quotes and sort of some helpful suggestions of how people can manage and cope. As Kim mentioned, you have a stoma after, and that gets reversed. How do you deal with that? What are the kinds of things that people found that they could or couldn't eat, or things that help them just cope and deal with that piece of this process? And then our patient connections part. Why do social connections matter before bowel surgery? Again, we try to explain each piece and provide the research that supports that concept. And then our frequently asked questions, very helpful for people to think about of what they can go to their doctor with to find out more. And that can, again, help with anxiety when you have some sense of things that you can control or manage or be engaged in. It's very helpful for patients at times to feel like they know what they need to know. And so that's a separate page. So you're probably here for, okay, what happened with all this? I'm super excited about the website. I think it's a wonderful piece. We spent about, I think we spent about a good 4 months every 2 weeks working on this website together for at least 2 hours. So it wasn't just a one-day workshop that I had originally planned in my budget. And thankfully we went online and it made this output. So we had clinical research coordinators with the help of Doctors Brown and Karamudin. In their clinic, they have CRCs, not chairs, but research coordinators that they have on rotation that helped us send out the letters of invite and deal with the ethics piece of contacting patients appropriately before they consent and inviting them if they were eligible. We recruited for about 9 months. And we had 33 patients who were expecting colorectal surgery at least 2 weeks or more from enrollment. We had the 2 weeks piece for 2 reasons. One, to give people a little bit of time to do something. And with the advice of our experts that at least 2 weeks minimum was necessary to see any kind of change, at least in terms of diet and possibly some of the other areas. And we had about 25 actually complete with follow-up information. So, a couple of patients after they consented, they felt, no, this isn't for me. I can't manage this at the time in terms of a study, or they just didn't follow up or what have you. You always get that kind of attrition. And so who were these folks? So the majority were about 50 years of age. So that means there's a fair number that were considered young in this area. They weren't, in their 65 plus years. They're younger adults or middle-aged adults, really. We had a rough balance of males and females. And, pretty decent BMI, no one really grossly obese or even obese, as probably would be expected for BC, with very low rates overall compared to the rest of Canada. So here's some qualitative feedback of this website. The information on the website made me aware of things I could do to improve the outcome of my surgery. It was great. I would highly recommend it to all surgical patients. Great idea, great info, and helpful. I would recommend it. I felt extremely positive after the surgery. For me, the more information, the better. Thanks again for providing this service. Here's a longer one. I'm going to just take a pause and allow all of you to read it on your own time. Great. So very, very positive feedback from the website. In terms of other sort of feasibility results, in terms of our clinical data, we found that only about 6 of the patients actually had what's called a subjective global assessment rating for being at risk of malnutrition. Now, this really ought to be standard and is thought to be standard for all patients that they receive this to determine, are they at risk of malnutrition? It doesn't actually measure their level of malnutrition, but just whether they're at risk, because about 40% of patients who go in for surgery do have malnutrition. That's from other data. So it's really important to know that. So this is an area for improvement, I would say, where we really would be great to have more patients assessed to just know whether they are or not, because of those who were, half were not normal. They were severely or moderately malnourished. And so again, extra emphasis in nutritional counseling could be brought in that prehab piece for those patients who are at risk. We had a patient satisfaction survey, and I'm going to show you the results of that. But just briefly, we only had about 1 patient report that they had requested nutritional counseling. 5, in fact, reported that they had received nutritional counseling. So 1 said that they requested it, and 5 said that they actually received it. So whether they requested it or not. No one, in fact, requested the active support through telephone-based health coaching. So this was a bit disappointing for us and was obviously very helpful for doing a feasibility study rather than doing a pilot RCT where we just went ahead and sorted that out, because maybe no one would have asked for it or very few would have. We need to rethink how we engage patients on that level, and whether it's just a fault of communication or whatnot. So also another area for improving the feasibility piece of that. So here are the first results of our patient satisfaction survey in terms of the actual website itself. So the blue is great. That's where people are very satisfied or somewhat satisfied. Green is neutral. And then there was 1 individual who appeared dissatisfied. So in terms of the website navigation and finding resources, you'll see that really the majority here were in the satisfied category. Documents were fairly easy to download for most people. They liked the layout and organization of the information. The level of detail that was provided was good. The quality of advice on the lifestyle factors. And then it was really more when we got into the nutrition counseling piece and the health coach piece, where it wasn't always clear if patients did receive it, and if they did, if not a lot, either it wasn't applicable because they didn't receive it or they were neutral. So again, areas of improvement. But overall, the large majority were satisfied with the overall experience of the website. In terms of the actual pieces that people did in terms of what they wanted, so did they intend to use the website? Were they interested in getting active support? A lot were. Most said yes. Most visited the website before their surgery. And we do have some high level information about HITs and things, but it's more ecological, and I left that out. Again, for those who received support, so some said yes, but they clearly didn't receive the active support because our health coach was never contacted. So maybe they thought the nutrition counseling they got was their active support. So a bit of communication piece around that. And people really did feel that it provided them with some support beforehand. And again, the overarching majority would recommend it. And the overarching majority did actually set some lifestyle goals. So what were some of those lifestyle changing goals? So how often did you work on some of these goals? Now, for many, smoking was not applicable, which is great news. We know that obviously BC, we have generally good lifestyle factors in that sense. So this might have been a bit different if it was Ontario or Quebec, perhaps. A large majority worked on physical activity at least 1 to 3 times per week, if not more. So the blue is a lot. It's like weekly work on it. And the healthy eating piece. So very few not applicable and very few not at alls in this. So a lot of people did work on it. Limiting alcohol, not as much, but for those who did, they did a lot of limiting. They did it every day. And then the stress reduction. Really great to see that a large majority were really trying to work on that piece. And that resonates and comes out in the literature a lot. It has been an area that's been absent, the psychological piece. So we also measured the self-rated health, the EQ5D5L. So for those of you in this area of implementation sciences and healthcare practice, you'll be very familiar with this. This is a tool that asks patients in 5 dimensions. So the 5D piece: mobility, self-care, usual activities, pain, discomfort, and anxiety, depression. In each of those areas, patients select the level of difficulty. So 1 represents no problems, and 5 recommends, unable or extreme level of problem. So you'll see that between the pre and the post, more patients reported problems after than before. And we measured this 3 months after, and we tried to map it with the kind of 3-month follow-up, partly for practical reasons, but it may not be useful as an outcome measure. We probably had to follow through and look at 6 months, maybe a year on. So a lot of these results were really not surprising to our clinicians, because after 3 months after surgery, especially major surgery, it can take 2 months just to recover. So this wasn't surprising. For anxiety, depression, there wasn't an increase post-surgery, so that's probably a good indicator, but it was just the same, really. So this, I'm not too sure what to think about this, other than perhaps we need to include in future, if we were to really run an RCT and look at like a patient-reported health outcome, such as the EQ5D, we might need more time frame for that. 3 months is clearly not sufficient to see a radical change from pre-post. For those of you interested in the means and the overall score, which you can calculate here, you can see overall, in fact, a brief summary of what you saw in the previous slide. The post overall was lower than the pre. Again, not surprising. I don't want to dwell on this too much. It wasn't statistically significant. Obviously, we had a very small sample size. And this wasn't the real point. We just, again, this was feasibility to see if this is, if it's implementable, do people fill in the form? And they did. So some qualitative feedback about the feasibility of this structured prehab. COVID happened, as we all know. So with all of its rules and masks and long surgical wait times, and it's not easy to access doctors, this individual felt that it didn't allow them to be nearly strong enough for their surgery. And that's fair enough, right? Major big life events are extremely disruptive over on top of a major experience like abdominal surgery. I just wish the timeline for the prehab was longer. So for a lot of people, it really only was about 2 weeks or 3 weeks. People felt it would indeed be more valuable to have more time. Again, same thing about that 2-week pre-surgery time frame. It felt constraining. Some people couldn't put all their full attention into the many components of the prehab on our website that we provide. And I'll just take a pause so that you can all read this. You don't need to hear my voice on this one. So this quote's really helpful for just sharing what a reasonable timeline might be. So this individual on their own initiated their own kind of prehab 3 months before. So I'm sure they found the website confirmatory for them and reassuring, hopefully gave them a few extra ideas or resources that they hadn't been aware of. But you know, this might be something to explore for future, to really look at the dose question, right? The duration piece of how long should prehab be before you really start to feel effects. So seems like we have a pretty healthy and astute group of folks. So that was useful here. Nearing the end, I thought I'd just share with you some of the key strengths and then also some weaknesses of this project. A major strength was that this was patient-oriented with 6 partners. Didn't just have one partner. I had 3 co-leads and 3 additional non-co-leads as part of my advisory committee. The website was co-created at every single stage and every single element was discussed. The content was expert vetted as requested by our focus group members, and it used that multimodal approach. It didn't just focus on diet and exercise. We had a lot of discussion around the psychological piece, which probably should also maybe include sleeping now in hindsight as well. And most importantly, for our implementation science colleagues, we had very strong leadership from our clinicians and our knowledge users from the start and now moving forward. And that's really absolutely essential. We probably could have had more support from maybe the other clinicians not involved in the project to help improve the communication around some of the elements, like the active support being available and how to reach out, and that we expected patients to reach out through the form on the website, or at least send an email. So some of the weaknesses, we did have some loss to follow up. Again, that short duration of waiting time for those who did use the website, there was probably low dose really. But even that short period of time, you know, people had some really positive things to say. A longer recruitment period could have included more patients and possibly with those with longer wait times. If we'd been able to extend this project, it was really only a 1-year project. It, of course, ended up being 2.5 or so with extensions, but maybe it really should have been just from the get-go a lot longer. And engaging our clinicians a little bit more on that active support arm. That was some of the feedback and discussions we had after the fact. And we also had some missing data. We didn't ask any patients about their SES information, and that might have been helpful to interpret the SGA results around malnutrition. As my other co-presenter who wasn't able to be here today, Marguerite, she suggested when she saw that the subjective global assessment in terms of the number of people who we did find were at risk of malnutrition, a lot of that could be due to food insecurity, and food insecurity could be due to very significant SES inequalities. And St. Paul's colorectal surgery is the provincial center for complex cases. So it sees everyone. It's not just, you know, the rich folks from Vancouver, although there is a lot of inequality in our city as it is as well. So some takeaways: this new patient-oriented website was very well received by our patients and appeared to be acceptable to a broad range of conditions, not just colorectal cancer, which again is where a lot of the literature has focused, is mostly in the cancer, but what about the non-cancer folks? A feasibility study was indeed useful to improve implementation of some components of the prehab program, as I've already mentioned. And the biggest piece that I am most proud of is that this website has now been approved by every single member of that colorectal surgery community and clinic. And it's been renewed by them, and they have fully integrated this into their standard of care. So this is their team. That website that I showed you where we had the About Us is no longer about us as a research team, but about us as the colorectal surgery clinic. Thank you, Heichka. Appreciate your time and open for questions.